Hello, everyone. Welcome to today's VMR. Today is another edition of our Teaching Point Recap VMR. And this is a format that we brought new quite recently. And we use this to kind of recap and touch back on old VMRs we had in the past month. We get to reflect on them. And there are always three people who kindly prepare a presentation and kind of share their teaching points and high yield things they want to pass on to us after some time of reflection on the case. And today we have three people who will be presenting. I'm really excited for this. We have Deborah, we have Mariana and Ibrahim who will be presenting a teaching point VMR reflection. And Deborah is going to be the first one to start. So I'll just ask you to share the screen and then go ahead if you're ready.
Thank you so much, Leah. Hello, everyone. I'm Deborah, one of the CPS Solvers team members. Let me just prepare my screen to share. How is it? Is it good? Everybody can see? Okay. So today I'll be talking about the case that we have last month in September, and was Rafael Medina, subspecialty pulmonary and critical care, was the case presenter, Dr. Dimple Saha, and the case discussion, Dr. Mangala Naharish. And the problem, the problem representation of the case was 34-year-old female that was pregnant of 16 weeks and presented with shortness of breath over the past 12 weeks. And 2 years prior, she had an episode of postpartum hypoxemia, and on physical exam was notable for hypoxemia in crackles and bilateral womb bases, and the CT showed diffuse cystis. Here, I try to start with this schema that I created. Wait, let me just, about the cystic lung disease, like that. What would be a cystic? A cystic would be a group of disorders with multiple air-filled loci surrounded by discrete walls that are less than 2 millimeters thickness, and we can see on imaging. And here divided where we can see the cystics, like in the upper lobe, in the lower lobe, and we can see diffuse. In the upper lobe, we can have all these differentials that could be a Langerhans cell histiocytosis, a PJP, hypersensitivity pneumonitis, paracoccygeal mycosis, and neurofibromatosis type 1. And in this case, we can start seeing that this differentiation will not fit. For a patient have the Langerhans cell histiocytosis, normally is associated with smoke. PJP normally is patients that are immunosuppressed. Hypersensitivity pneumonitis, normally there's inflammation because of an antigens and can have ground glass opacity. Paracoccygeal mycosis is normal persons that live in rural works in South America. That is not the case. And the neurofibromatosis type 1 normally is diagnosed in childhood, and the patient has some lesions on the skin. So not anything that our patient was presented. Going for the lower lobe, we had the Barth-Hoge-Dude that it is in this case is more in the lower lobe, is not distributive, and the patient could have some skin tumors, lung cyst, and a pneumothorax, stuff that was not presented in our patient. The lymphocytic interstitial pneumonitis normally is presented in patients with a Sjogren or immunocompromised with HIV. Follicular bronchiolitis, it's normally associated with collagen vascular disease and immunodeficiency. And the last one, the squamative interstitial pneumonitis, is associated with smoke. So none of those, but it is a good schema for we trying to know what we should think about when we see a patient with cystis. And going for the other side, we have the diffuse. That was our case, that the first differential is LAM. The second was light chain deposition, that it's a lymphoproliferative disease associated with myeloma multiple. And the third, it could be a cystic pulmonary metastasis that normally is a metastasis malignancy. So in this case, our patient had like the LAM. And I here put like some high information like about the disease. It's extremely rare, what happens in young female, and can be hereditary or sporadic. Hereditary can be associated with tuberous sclerosis complex. When I was preparing, I never heard about this disease. I don't know if anyone had heard or know much about it. Please put in the chat so we can make more interaction. I never heard too, Maddie. It's like a genetic disease that causes non-cancerous tumors in different parts of the body. So this disease, some mutations of this disease can make a mutation of LAM2. And that it is like 30% of this disease is associated with LAM, and was something that I learned, and could be sporadic too. And the pathogenesis is unknown, but there's like a proliferation of muscle-like cells, and they proliferated a lot. And these cells, they have like estrogen receptors. So like human that are doing pregnancy, taking oral contraception, fertility, can have like a more probability to have this disease. And that was our case, that the woman was pregnant and has a slow decline after the menopause. And here is the typical presentation. Normally, it's a premenopausal woman with 30, 40 years old with dyspnea in exertion. And I want like you all to make an exercise and think what would be a differential diagnosis with this presentation in a young human. Like, because a lot of times this disease is like it's misdiagnosis, because like no one will say as a first thought, okay, it's LAN. We go for asthma, we go for COPD, maybe like a PE, someone said in the chat, amniotic emboli, perfect, and like a pulmonary hypertension. So sometimes it's misdiagnosis or confused with other diseases, anemia, perfect, Mark. And another thing that we see, it's dyspnea and exertion. And the case discussion on the day, she said that she had a patient that had dyspnea just when she had sex. So like it could be something that, you know, we can not expect it. And it's like, besides the dyspnea, we can have fatigue, spontaneous pneumothorax, chylothorax, and the physical exam, wheezes, hyperinflation, decrease of abscess, breath sounds, crackles. And we can have affected the kidney with renal angiomyolipoma that could be asymptomatic or can have some manifestations of hemorrhage if the lesion is more than 4 centimeters. And the lymphatic system can have the chylothorax, lymphadenopathy, and lymphangiomas, that non-cancerous fluid fillet cystis. So these are the basic, the most common presentations. And when we go for ordering the test for diagnosis, like the BFT, it's really a specific too, because a lot of patients can get normal, obstructive partner, a restrictive. So like it doesn't help the diagnosis. And what is a really hallmark of the disease is the cystis. Like we can see in the CT, they are diffuse without a lobe preference. They are bilateral and well defined, as you all can see here in this image from the case. Another thing that we can order is for abdominal CT to see the kidneys. We can see the lymphadenopathy and lymphangiomyomas. And another interesting fact, like it's that has and this levels of VEGFT, it's really elevated, like more than 800. And it's like something that makes us think about the disease. And we can others like some other tests for do a differential diagnosis, alpha-1 antitrypsin, serum proteins, electrophoresis, free light chain quantification, and some antibodies to like exclude like any rheumatological disease. Here I make like a something for we think together, like how we can confirm the diagnosis. Like normally it's the clinical presentation in the chest CT with the cyst that I just showed, and then we can check if the patient has the TSC, and if the patient has, that is like really like we can confirm the diagnosis. If the patient doesn't have, we can look for other images, the angiolipoma, lymphangiomyelomas. And if the patient has, we can confirm the diagnosis. If the patient doesn't have, we can order the VGFT. And if it's high, we can confirm the diagnosis if it's not. Of course, like we go excluding the LAM diagnosis here, and then we can go thinking for other diagnoses that this patient could have. But all of these things that I added, they are like really high yield to help the diagnosis. And we can confirm the chylo and the pleural effusion or ascites. We can look for the presence of a LAM cell by cytology. And like I saw that one of the last things that we could do is a transbronchial lung biopsy or surgical lung biopsy, or we can, like I said, check for another diagnosis. Oh, there's a question. No, I'll finish my presentation and answer the question. And I add here like some, like just additional information, like of the treatment. The first line is sirolimus that stabilize the lung function and improves the quality of life. And something interesting that is not it's a suppressive therapy, not curative. And this patient that we had couldn't receive because she was pregnant. She had to go like for a specific center to get like a treatment. A second line, we have like the everolimus, and we treat to the complications, pneumothorax, chylothorax, and if the disease is really refractory, we can go for lung transplant. Yeah, going for the end of my presentation here, I had like some key points that I want everyone to remember. That normally it's for a young human, premenopause, and has a high prevalence in pregnancy, can be hereditary associated with tuberous sclerosis complex or sporadic, can have some manifestations like in the lung, that the cystis renal, that could be angiomyolipoma, and a lymphatic involvement. On CT, we have diffuse cystis without a low preference, and the level of serum VEGFD are normally super elevated. So yeah, these are my references, and thank you, everyone. I think I saw a question, interesting question in the chat. Oh, if there is any specific pathophysiologic, no, it's a no. I was looking at that too, trying to find like an explanation. There's like some proliferation, like some genetic that is involvement that with the proliferation of a typical muscle cells, but not something that it's, you know, that we know for sure. That's what I read about it. Yeah, thank you, everyone.
Thank you so much, Deborah. Thank you for your presentation. I think we were all blown away, one, by how easy it was to follow your slides because of how well you did the structure aesthetically too. So thank you so much for that. And I think it's really cool because I also remember listening to the VMR, and me neither. I didn't hear, I had not heard the diagnosis before. And also even just to kind of spell it out, right? I think it's definitely a word to remember for Hangman next time to when you play it. But yeah, just getting a rare disease, and we don't encounter it often. So thank you for bringing it back, and also making us think of the differential diagnosis with this clinical vignette. I wanted to ask, is there anyone who still has a question concerning this case? So feel free to pose it or put it in the chat. Yeah, I agree. Pronouncing it and solving it, both difficult in this case. If not, then I think we can go on to the next presentation, which will be Mariana. Mariana, if you're ready, feel free to share your screen.
All right. So, can you see my screen?
Yes.
All right. So, hello everyone. My name is Mariana.
We
Go
can
ahead,
see
Leah. Do you want to say something?
the presentation is not shared yet, so we can see the whole screen, but it's not
Okay.
in presenter mode yet.
Let me try again. What about now?
Perfect.
Okay. So, hello everyone. My name is Mariana. Thank you, Leah, for the presentation. And congrats, Deborah, for your amazing case. And today I'm going to present the VMR recap. I'm also one of the CP Solvers team member, and I hope you enjoy. This case was presented by Aisha and discussed by Shema and Dr. Rabi on September. So I'm going to start with the problem representation here. Um, I'm, I'm, okay, now it worked. So in the problem representation, we had a 35-year-old female with past medical history of lupus and complaints of chest pain on exertion for 1 week. And something that I thought really, really interesting in this case was when how Dr. Rabi and Shema, they approached the chest pain associated with a previous diagnosis of lupus. Of course, we have to rule out the life-threatening causes as we do with every patient, but after that, we can think in a different way. We can divide it in lungs, vascular, and heart secondary to medication. And when we think in lungs, we could consider pleuritis or pleural effusion or diffuse alveolar hemorrhage or pneumonia secondary to corticoid use. And something that is interesting here is that if the patient had a lung condition, it would not appear with chest pain on exertion. We would expect shortness of breath on exertion. So it's less likely here in this specific patient. And if we consider vascular cause, we could think in coronary dissection, APLS, that is the antiphospholipid syndrome causing coronary thrombosis, or Liebman-Sachs causing coronary embolism, or coronary chronic arterial disease, causing acute coronary syndrome or pulmonary embolism. And also we could have heart conditions caused by the medications that we use to treat lupus. That could be like infiltrative cardiomyopathy or myocarditis. I did not include the medications here on purpose because I would like to ask you guys if you will remember which medications could cause like CMP or myocarditis. And you can write in the chat. I'll be looking here. So we would have like a lupus medication that would be causing like infiltrative, CMP, and myocarditis. So I see steroids here. Anyone has another guess? Yeah, Hans cited hydroxychloroquine, and that is correct. So we could expect tacrolimus causing infiltrative CMP and hydroxychloroquine causing myocarditis. So to have a better idea of what is happening with this patient, we need more data. So we know that the patient was on apixaban, hydroxychloroquine, mycophenolate, belimumab, tacrolimus. And also this patient had an episode of pulmonary embolism 2 years ago. And we also know that her labs came back positive for beta-2 glycoprotein 1 antibody and also increased APTT. With all of this information associated with the chest CT that the patient that was performed, we could diagnose pulmonary embolism secondary to lupus and antiphospholipid syndrome. So how can we diagnose this, can make this diagnosis of antiphospholipid syndrome? We need to have one or more clinical manifestations that could be like arterial or venous thrombosis associated with persistent evidence of antiphospholipid antibodies. And what do I mean by persistent here? Well, we have drugs and also infections that could cause like a transient increase of antiphospholipid antibodies. So we have to repeat these labs in 12 weeks to be sure that is a true antiphospholipid syndrome diagnosis. And which are these antibodies? We could have like anticardiolipin antibodies increase, or anti-beta 2 glycoprotein increase, or lupus anticoagulant increase. And something that I was researching and I found really interesting here is that the increase of anticardiolipin antibodies would characterize a low risk profile of a patient, and at the same time, an increase in lupus anticoagulant would characterize a high risk profile for a patient. So it's interesting to measure all of these antibodies to better characterize your patient in low risk profile or high risk profile. And something that is important is that increasing the APL alone would not close the diagnosis for APLS. You need to have a thrombotic event or pregnancy morbidity to have the diagnosis of antiphospholipid syndrome. So coming back to our patient, now we have a patient with lupus and antiphospholipid syndrome with two previous events of pulmonary embolism. So this patient needs a secondary thrombosis prevention. And I would like to ask you guys again, what do you do for this patient? Would you maintain her on a apixaban, or would you switch to heparin for 6 months, or would you start lifelong warfarin? Yeah, so yeah, Hans has the right answer again. So we should maintain this patient in lifelong warfarin. And this was discussed in the case and was really, really interesting. So patients with APS, mainly after a venous thrombotic event, should be maintained on warfarin, except if the patient is pregnant. In this case, she should use low molecular weight heparin. And the use of DOACs can be considered in patients of low-risk disease, and those who cannot tolerate warfarin also should use DOACs or low molecular weight heparin. And what if your patient experiences a thrombotic event while using warfarin? Well, in this case, the first thing to do is check INR and see if it's in the correct range. If it's not, you should look for possible interactions, medication interactions, and if it was in the correct range, you should switch from warfarin to low molecular weight heparin. All right, so here I have my takeaway message. That is, lupus associated with chest pain. We can have a different approach to assess this patient. Of course, we can't forget to rule out the life-threatening conditions, but after that, you can assess that in a different way. And APLS is highly associated with lupus. We can't forget that. So if a patient that has a previous diagnosis of lupus appears with thrombotic events, you have to think in APLS as an associated diagnosis. And last but not least, APLS. If your patient has APLS, they may need lifelong warfarin anticoagulation. So, and why I included may need, because it can be really specific according to your patient, according to previous diagnosis, and also according to if the patient is low risk profile or high risk profile, but they may need lifelong warfarin anticoagulation. So always remember to think about that. And here are my references. Thank you.
Thank you, Mariana, for this wonderful presentation. I think you managed to break down such a complex topic into so simple slides and make it clear again. And I also loved how you walked us through thinking about the management, the anticoagulation of this disease. Is there any question from the group? Please feel free to ask. If not, I'm curious, I have a question. Do you happen to know, because I didn't know about the high risk, low risk profile according to the types of antibodies. Do you know if that has any consequence for the management of the patient?
Yes, this is really, really interesting. So what I read until now is it's really specific according to your patient, because, for example, if you have a patient with lupus, like the patient only because of the lupus already has like increased chance of thrombotic events. So you have lupus associated with APLS. You have to think about even primary prevention. So, and also when you have a patient with a low risk profile, you can think about maintaining this patient on DOACs. And if you have a patient with high risk profile, you have to maintain this patient on warfarin. So it depends of each patient. It's really interesting, but it's also difficult to say what is wrong and what is right. It depends on each patient.
Okay, thank you so much. That sounds super interesting. I'll definitely read up on that. I see we have another question in the chat from Shreyas. Question is, he's wondering how the PE presented over a week. Is it common for PE to have a subacute presentation?
Oh, actually, it was discussed in this specific case. I don't know I don't know the specific answer for that, but if I have to guess, I would think that it's not common, but it could happen. If someone wants to help me with that.
Yeah, I also totally agree. I think I would also think depends on the localization and how hemodynamically relevant the PE is. And just thinking about how chronic thrombus can also cause pulmonary hypertension, just remembering that there are like chronic cases of thrombosis in the lung vasculature. So I definitely think there are various time courses in which a PE can present. So yeah, I agree
Totally
with you.
agree.
All right, amazing. If I don't see another question in the chat, so I think Ibrahim, if you're ready, we can go ahead. And I see you already shared the screen. Ibrahim is
Yeah,
also part of the TMR TP Recap VMR team, and really excited to hear your presentation.
thank you, Leah. So hello, everyone. Good morning, good evening, and good afternoon, wherever you're joining us from. My name is Ibrahim Omar, and just like Leah mentioned, I'm part of the TP Recap VMR team. So today I'll be presenting a case that was actually presented 2 days ago on the student VMR by my very dear friend Mario. The case discussants for this case were Dr. Jasdeep Bajwa, as well as Dr. Alex Smith. So the problem representation for this case, this was a 54-year-old male who seemed to have hyperacute loss of consciousness, as well as focal right hand weakness. It seemed that this guy had all of his symptoms develop within the span of 24 hours. So along with his clinical history and the imaging findings that showed vasogenic edema and ring-enhancing lesions, this guy was eventually given the diagnosis of neurocysticercosis. So before going on with our presentation, I just wanted to ask a question in here. Say, for example, that you're actually a physician and you're working and a patient comes into your office, and after taking history and doing clinical examination, you suspect that your patient has a cerebral infection. Which of these following points would be the highest yield in actually building a differential diagnosis for this patient? A, knowing their immune status, knowing their family history, knowing their vaccination record, or knowing their travel history. So you could use the chat, and I'll see the chat. Okay, so I can see that the majority are actually sending A, the patient's immune status, which is the correct answer. So when you actually suspect a brain abscess in a patient, the first thing that you need to do is look into whether or not there is lung involvement in the patient. And you have to be aware that brain abscesses actually take time to develop. So they do not develop overnight. So even if a patient presents to your office without a lung involvement, it may be that the lung involvement has resolved by the time they are now presenting with the brain abscess. However, if the patient only has a brain-limited disease and they only are presenting with brain-limited abscesses, you have to think, as we've mentioned, and as the majority have mentioned, whether the patient is immunocompromised or immunocompetent. This is because the differential diagnosis actually differs in either of the two categories, primarily because patients who are immunocompromised are vulnerable to specific organisms. And so in immunocompromised patients, you typically have to think of amoebas and parasites. And amoebas, you can think of acanthamoeba and balamuthia. And in parasites, you can think about toxo and trypanosoma. And in all patients, immunocompetent patients, you can also think of amoebas, parasites, and molds. However, the differential diagnosis in each of the categories will differ a little bit. However, in parasites, you have to keep neurocysticercosis at all times, which this patient actually ended up having as a diagnosis. So your radiological approach to cerebral infections on brain MRI, this will be the main topic of today's presentation. However, before we go on to the MRI basics, I wanted to ask this question. If you can recall from your high school chemistry or from your undergrad chemistry, which of the following chemical elements is the single most important in creating images via the MRI? Again, carbon, hydrogen, nitrogen, or oxygen. Okay, so some people are saying B. We must say H. Okay, so the correct answer is actually B, hydrogen. And there's a reason for that. Reason being is that hydrogen actually, if you recall from the periodic table, unlike the other elements, only has one proton but does not have an electron. There are forms of hydrogen that do have an electron, but the most common form that is found in the body is the H plus that only has a proton. And because it only has a proton, it means that it carries a positive charge. And because it carries a positive charge, it means that it's intrinsically polar. This is important because if it's intrinsically polar, it means that if it gets into a magnetic field that is stronger than the field that the hydrogen atom carries, it will align with that magnetic field. And this is typically how an MRI would work. Another important point as well is to remember that most of us are mostly made of water. And because we have a lot of water, we have a lot of hydrogen. And because we have a lot of hydrogen, this means that we have a lot of resolution and definition on MRI imaging of our bodies. And so typically, if you go into someone's body and you look into the hydrogen atoms, and this is basically oversimplified, you'd find that the vectors of these atoms would be very random. So they wouldn't align in a specific whether linear or planar field. However, when we bring on the MRI and the magnetic field that it carries, then all of these hydrogen atoms would actually end up aligning their vector according to the vector of the MRI's magnetic field. And then we actually give off radio frequency. And what happens is that after we give off the radio frequency, that these vectors change in 90-degree angles. And then we take off the radio frequency. And what happens is that because we took off the radio frequency, the vectors once again realign into the longitudinal plane. And when they do align into the longitudinal plane, what happens is that they give off energy. And then that energy itself is actually what formulates the image that we see as an MRI image. So important tips that you need to keep in mind that would help you in actually looking into an MRI image and being able to understand the pathophysiology or the physiology behind the image itself is to differentiate between magnetic resonance imaging. So I'm pretty sure the majority of people in here have heard about T1 and T2 weighted imaging. So T1 is typically longitudinal relaxation time and T2 transversal relaxation time. I know that it seems a little bit complicated. However, when you actually think about it, it's not that complicated. Reason being, if you remember in here, I told you that there is the initial longitudinal plane, which then changes into the transverse plane. and then once again returns into the longitudinal line. So the time that the atom takes in order to change these into transverse and once again into longitudinal is what creates the difference in imaging between the T1 weighted images as well as the T2 weighted images. Another important point that you also have to keep in mind is that in the T2 images, water will always appear white. There is an easy way by which you can remember this, is that to remember that H2O has the number 2 in it, and T2 has the number 2 in it. So T2 equal H2O, always white. And this obviously does not only relate to water, but all water-containing substances, including CSF, urine, etc. Another important point as well is that in T1 and T2 images, fat and hemorrhage can both be bright. So it seems that it's only water that actually has this quality, where it appears as white on T2 and appears as darkened or black on T1 imaging. And then there's also something known as the flare sequence that we see on MRI. This is typically the same as a T2 weighted MRI. However, it's without the water. And so if you take off the water, you might ask the question that, well, if you took off water, how are we going to differentiate between T2 and T1? You typically can differentiate by the white matter and the gray matter, where the white matter will appear darker than the gray matter on the flare sequence, whereas it would be the other way around. So it would be white matter brighter than gray matter on T2 imaging. Okay. So before going on with the presentation, there's another question, and it's actually important clinically. So how long do you think would a brain biogenic axis take to fully develop inside someone's brain? Is it 1 month, 2 months, 1 week, or 2 weeks? Okay, people are saying 2 weeks, D. Okay, I can see some B. Someone said 1 week. Someone is saying 2 months as well. 2 weeks. Okay, so, and someone is saying A, 1 month. So the correct answer is actually 2 weeks. Now, the most important thing about this question is not to remember the number. Obviously, the number is not that important. What you need to remember is that it takes time to develop a pyogenic abscess, i.e. someone who would have just gone into bed and woke up the next day, and then they're complaining of something in their head. Most likely, this would not be a pyogenic abscess. A pyogenic abscess takes time to develop, and you need to take that into mind when you're actually looking into the radio images and you're looking into different pathological masses in someone's brain. So we will not be talking about all masses that are found in someone's head MRI or brain MRI, but we will actually be limited to pyogenic abscesses, tuberculomas, cryptococcus, as well as neurocysticercomas and toxoplasmosis. So this is a pyogenic abscess. And if I may ask for help from someone, can you help me explain what you can see in this image? You can use the chat or you can open your mic. Okay, so Madi is saying well-defined ring enhancing region. That's absolutely correct. So what you can actually see in the pyogenic abscess is that you have the typical ring enhancing lesion that you see in someone's brain. However, as I've mentioned, pyogenic abscesses actually do take time to develop. So if you take someone to the MRI and you do an MRI for them and you don't find the pyogenic abscess, it does not necessarily mean that this patient will never develop a pyogenic abscess. It may mean that the pyogenic abscess is now negative in imaging and will appear soon after. Sometimes there could be some signs that could clue you into whether a patient is now developing a pyogenic abscess, and those could include hyperintensity in T2 images. And so this is the tuberculoma. So if you compare and contrast the tuberculoma as well as the pyogenic abscess, you might notice that they look fairly similar in comparison to each other. So the way by which you actually differentiate between both of these images, so you can see that this one is actually a hyperlucent abscess that you can see in here. The way by which you can actually differentiate is that if you look into the T2 weighted images in here, you can find that there is a center in the middle. There is a hypointensity in the center. And this hypointensity in the center is usually only seen in tuberculomas. So if you see a hypointensity in the center, this is typically the most highest yield feature that is found in tuberculomas and is not found in pyogenic abscesses. Okay, so another question. Say, for example, that a patient comes into your office and they have been diagnosed with HIV, and they tell you that I have seen that patients with HIV are more susceptible to cryptococcus. At which CD4 level would you tell this patient that they should start worrying about being susceptible to cryptococcus? Okay, so people are saying, almost everyone is saying A. So that's actually the correct answer. So 100, and this has a clinical a bridge to it. So it's not just important to know the number. It's important because in certain countries, so not in all countries, typically only resource limited areas, if a patient comes in and their CD4 count is less than 100, you want to start them on prophylaxis for cryptococcus. I'm going to ask again, does anyone know what is the prophylaxis for cryptococcus for patients with a CD4 less than 100? Right. So Marino said it. Yes, you can start the patient on fluconazole, and you could also start them on itraconazole. Right. So this is a patient who developed cryptococcus. So you can see that in this patient, they have something known as perivascular dilatation. Reason being is that these are not actually the cryptococcus. These are the cryptococcus migrating through the brain. So when they migrate through the brain, they obviously travel through the vessels and they leave off these pseudocysts surrounding the vessels themselves. So you can see there are some pseudocysts in here and you can see some pseudocysts in here. Another feature that is also important that you can look for is hyperintensity within the basal ganglia. So you can see that there is some hyperintensity here, there's some hyperintensity here, and these all could clue you into cryptococcus. There's also leptomeningeal enhancement, and the leptomeningeal enhancement is typically seen at the base of the brain. So you can see it clearly in here. Okay, and then this is a patient who actually developed neurocystic sarcosis. I'm sorry for the image, but this is the only public domain image that I found online. So what you need to know about neurocystic sarcosis is that the disease actually, just like pyogenic abscesses, it goes through different phases. It goes through different stages until you find the final stage. And typically it starts with these viable lesions. This is typically the first stage, and it ends with the calcification that we saw on our student VMR. And so how do you differentiate this from pyogenic abscesses or tuberculomas? Is that typically you'll find a dot in the middle. And the dot in the middle is typically the solix of the tapeworm itself. So the solix is the most interior part of the tapeworm. And when you see this, you know that this is typical feature of a viable stage of neurocystic sarcosis. And then finally, we have the toxoplasmosis. So toxoplasmosis typically appears in periventricular lesions, in periventricular areas, of patients who have HIV. And those periventricular lesions are actually important because sometimes they can be confused with another thing. And the other thing that they can be confused with is primary CNS lymphoma. So I just wanted to ask a question. Say, for example, that you have a patient who's, again, presenting to your clinic. They have HIV or AIDS, and you're looking at this image and you're suspecting whether this is toxoplasmosis or lymphoma. What can you think of that you could order for this patient that would be able to rule out toxo or CNS lymphoma? Okay, toxo antibodies. Okay. Right. So you could definitely order toxo IgG, and on a radiological basis, what you could also do is that you could order an FDG PET. So an FDG PET would typically show increased avidity in patients who have primary CNS lymphoma, whereas it wouldn't show increased avidity in patients with toxoplasmosis. So it would be able to differentiate both of these from each other. So take-home points from this presentation. Always remember the most common primary CNS infections in HIV persons, including HIV encephalitis, which is the most common. Then toxoplasmosis comes next, and finally cryptococcus. And then differentiated tuberculoma from a pyogenic abscess using central hypointensity on TT-weighted imaging, as well as taking the clinical features, of course, in mind. And then the prophylaxis against cryptococcus in AIDS patients with CD4 less than 100 is only limited to resource-limited areas. So if a patient is coming in an area where they can easily access care, typically those patients do not need to be put on prophylaxis against cryptococcus. And then finally, pyogenic abscesses take time to develop. So remember that if a patient is presenting with you right now and they don't have pyogenic abscesses, this does not rule out the entire chance of them developing pyogenic abscesses in the next 24 hours or in the next few days. So these are my references, and if anyone has any further questions, I'd be happy to answer them right now.
Wow, Ibrahim, this was honestly masterful teaching. I think we're all stunned by how you were able to, one, go through the mechanisms of MRI and how that works. And then just have such a clear, like also visual, so that we can understand and fully follow. I saw that there was one
Thank you.
question by Matt in the chat. I
Okay.
think the question was concerning LDH, whether it was elevated in toxo and in LDH. Am I right? Did I get the question right? Whether you can use LDH to differentiate.
Between both. Right. So there's actually, you typically need to take in the full picture of the patient. I haven't read on the clinical side of it, but on when it comes to a radiological aspect of differentiating between toxoplasmosis as well as primary CNS lymphoma, you don't want to treat the patient for toxoplasmosis and then find out after a couple of weeks or months that they had originally lymphoma in the first place. And so it wouldn't hurt the patient if they underwent an FDG PET just for a final confirmatory. But for an LDH, I don't know the negative predictive value that that would actually carry.
Well, thank you so much. If there's any other question, feel free to post in the chat. In the meantime, I'm curious, Deborah and Mariana, how did it feel for you guys to present? I know it can sometimes be, presenting in front of people or preparing something in advance. I know sometimes the mind can go places, or it's also just something you can look forward to because it's a way to share and show what reflection happened actually after the VMRs. So I'm just curious, how did it feel for you? Maybe Deborah, if you want to go first.
It was really good. Like, it was my first time doing the teaching point recap, and nothing. I don't think we need to be nervous or like worry about. This is a safe space. We are all learning together, and I think it's a great opportunity for everybody grow together and and learn. So nothing. I really want to motivate the team to participate and encourage to help this project to keep going. Thank you for the opportunity.
Yeah, I totally agree with Deborah. I have nothing but like wonderful things to say about this experience. I learned so much. I had the opportunity to really focus on the theme and learn a lot. And now I'm studying for my step 2 CK now. And now every time that I have a question of lupus or APLS, is so much easier because you have the opportunity to really study something and to think in a good way to explain to other people. So I really like this experience. Thank you so much for this opportunity, and thank you for the VMR recap team for creating this space. It's really, really nice. Thank you so much.
Thank you for making this possible and preparing these presentations. I know there's a lot of work that goes into this, and I was just blown away also by your presentation and by the slides. I mentioned earlier before when we talked that I think even if I tried hard, I would not be able to make such nice slides to the way that you were able to today. And yeah, so thank you for that. And I think we touched on a lot of different subjects. We started off with cysts in the lungs, ended with cysts in the brain. In between, we discussed management of APLS. So there was definitely lots of recap here today, lots of new ways we can reflect and go on thinking. So thank you so much for spending this time learning again, growing together. And yeah, I didn't see any new questions in the chat. So I guess we'll end the session here. Thank you for joining, and hopefully see you next time. Goodbye.